All right, thank you very much, Dr. Kalichman, Dr. Pachenkas. We invite you to the table, and we have our very first question from Willie Prado via the phone, via Amy.
Yeah, so this is from Dr. Prado. So he has a question for each of you. So for Dr. Pachenkas, are there current macro level or structural interventions that you know of which have been found to decrease structural stigma in a defined space, for example, at the community level? And just so I don't have to come on again, I'm going to ask Dr. Kalichman, now I can't say your name. You've messed me up. What do you think is the most important barrier to scaling up effective behavioral STI preventative interventions?
So I can try to answer the question on effective interventions to reduce structural stigma and circumscribed spaces. I mean, we have to consider, in the case of MSM, for example, we have to consider the institutions that surround them. That includes schools, families, religious organizations, et cetera. At the school level, there are things like gay-straight alliances, which Stephen Russell's work has shown that with schools that have a gay-straight alliance, typically led by kind of one courageous teacher who posts a note saying, come to my classroom if you want to discuss issues related to LGBT things, can have incredibly powerful interventions on making young people feel included in school environments. To my knowledge, the impact of GSAs on STI risk hasn't been evaluated, or even the ability to use GSAs as forms to reaching young people who might otherwise be closeted hasn't been considered, but it's certainly a good area for consideration. Religious communities, there's long been talk of building healthy, or building LGBT affirmative support within religious organizations. Mark Hatzmio and I have shown that the religious affiliation of one's county predicts sexual risk behaviors among LGBT youth living in that county. But I don't know of any kind of circumscribed interventions that have particularly worked with religious organizations to influence STI risk by specifically reducing their stigma towards MSM. And then family-based interventions. I mean, a lot of the work that we do in our interventions kind of replaces the job that parents should have done, right? Making their kids feel belonged and included and worthy of keeping themselves healthy. To the extent that parents can be made to feel that parenting as an institution can be used as a route to helping parents feel okay about accepting their LGBT youth and having conversations about sexuality that young MSM aren't otherwise getting, I think could also be a powerful intervention, but to my knowledge hasn't been robustly tested.
So the question is on various barriers to sustain. Sorry.
He said, what do you think is the most important barrier to scaling up effective behavioral STI prevention interventions?
Yeah, so like I say, I think that there's really a very large toolbox of these interventions. Can you hear me okay? Yeah. And so I think that the barriers have really been buy-in, the belief that sort of understanding and believing the evidence that the interventions actually are effective and will prevent infections. I think buy-in has been a barrier, and that has led to a lack of investment. And so certainly that's the case in STI. I think it's also true now in behavioral interventions for HIV prevention. The investment is gone. And the buy-in has always been tenuous.
Okay, we've got Ned and then Case.
Thank you for your presentations. It occurs to me that more than half of gonorrhea and chlamydia infections in women occur in women who have only had one sex partner in the last year. Are the dimensions of stigma experienced by those women different? And does that impact efforts to intervene?
I mean, if I understood your question correctly, do women experience the stigma of their STIs differently than?
Well, also the issue of monogamy, okay? Most of the women who are getting infected with these are infected by partners who are non-monogamous. And so how does this impact their vulnerability, acceptance is a better word than vulnerability, to interventions?
My non-empirical guess would be that that monogamous women who have been infected by a partner might experience greater stigma because it wouldn't be normative or expected in their communities like it might be for MSM, for example, and the ability to to perceive blameworthiness and to perceive disgust and that yourself are at risk and putting others at risk, I think could be exacerbated. But
So are the interventions the same?
I would think that the interventions for women who are surprised by an infection because they've otherwise been in monogamous relationships would really rest on providers delivering the diagnosis. I mean, if providers could somehow explain the realities of disease transmission and what this disease means, I would imagine that could be, if not sufficient, at least reasonable. I mean, the model we've taken with young MSM is that these STI risk is driven by a multitude of kind of syndemic factors that we know, including disproportionate risk of mental health problems, of substance use problems, et cetera.
Well, yeah, I mean, I think that the dimensions of stigma are wide, and so how women with STI experience stigma, I think the different dimensions. Well, the most striking difference to me, though, in terms of interventions for men and women for STI is healthcare delivery systems. So I mean, women have a reproductive health venue for routine STI testing that men just do not. And so when you think about reproductive health clinics and the role that they play in detecting and treating STI, that's pretty huge with women, and there's no parallel to it in men.
So just to sort of rephrase what you said, our interventions for reducing stigma in women need to focus on providers, whereas for men, we're dealing more with outreach and community-based activities.
Yeah, I mean, in the immediate term, right? Because in the long term, I think you can correct me if I'm wrong, but I think there's a big movement in HIV prevention for men who have sex with men to rebrand essentially HIV STD prevention into sexual health, and into and the sexual health prism is very, sort of would run in parallel to reproductive health with women. So I think there's structural efforts there, but in the moment, that would make a lot of sense to me, that to really make sure that providers have ramped up their detection and treatment capacity for women who are receiving a variety of other health-related services, particularly reproductive health. And for men, I think you require much more intensive outreach to men. I think that self-testing is, particularly for rectal gonorrhea with men who have sex with men, I think is a priority.
Thanks. Thank you for those presentations, and I'm glad that there is still advocacy for behavioral interventions and that you keep at it. That's great. My question really has to do with the changing sort of backdrop of behavioral interventions. I mean, clearly in the last 15, 20 years, the perception of HIV/AIDS as an invariably fatal disease has significantly changed due to biomedical interventions, and it stands to reason to think that your behavioral interventions, will have a more difficult time actually to achieve effects against that backdrop, because a lot of it has been driven by the perception of HIV as a bad actor. So what kind of repercussions does that have for behavioral interventions and the messaging that we try to convey?
Yeah, so I think that behavioral interventions have, to a degree, and can to a much more degree, adapt to the changed and changing environment. And so from my own perspective, I think that the big gaps here are behavioral interventions tagged to HIV testing for people that test HIV negative. To me, that is a huge missed opportunity for preventing STIs and HIV. And then building in a stronger, I think, sexual health component. I always say this, I always say if you want HIV treatment to be prevention for people that are living with HIV, you have to provide them with the health services that people got in HPTN 052. I always say that. And so you know, that included, you know, every 4 to 6 months, people were getting tested and cleared of STIs, and along with other health services. And so in that context, we know that you don't get HIV infection. So I think ramping up sexual health, STD detection, and preventive behaviors and that would be individually tailored for people living with HIV is, I think there's a big gap there right now, along with you know, interventions for people in high priority places. I think that there's a home for behavioral interventions in places where we know they're needed, like substance abuse treatment service centers never really been scaled up, mental health service delivery centers never really been scaled up, social services, along with STD clinics. So what's interesting to me is that there is a real toolbox of behavioral interventions that may need tweaking, may need reinventing, can be digitized, that are the result of a significant taxpayer investment.
If I could just add briefly to that. A few years ago, the number of years of life lost to MSM from HIV was surpassed by the number of years of life lost to MSM by suicide. If you ask the average young gay or bisexual man what type of service they're most interested in, they'll say something like mental health services. The disparities in mental health problems, including depression, suicide, are astronomical in this population. And the unmet needs that many of them will refer to or lack of mental health services. Obviously, depression, anxiety, substance use co-occur, sometimes quite directly with risk for STIs and HIV. And so to the extent that we can remember that the demand for services is often for something other than STI prevention, but as Seth was saying, to fold in, to use those services as an opportunity for STI prevention, I think could have substantial effect.
The question answered?
So I had so much trouble getting my mind around, like, the evolution, as you were talking about funding and the trajectory of how we think about these problems. This morning, Laura Cheever, in her talk, discussed the high incidence and prevalence of STIs in people with HIV, but it wasn't like she mentioned, and this is not meant to be negative, she didn't mention, well, shouldn't we be doing something to try and prevent those events, right? That wasn't really part of the dialogue. Let's just detect them and treat them. Now, in the PrEP space is so ubiquitous in the end of AIDS plan that the behavioral strategies are how to get people on PrEP, and there's a lot of experts at this table, how to get people on PrEP and to be PrEP persisters, right? But then the STD problem gets lost in there. Not that that's the whole STD problem in the United States, but it's a part of it. And I have trouble getting my mind around, well, what should we do? I mean, I have no idea I have no idea what we should be doing. So why don't you talk, Seth? You've been doing this a long time. What should we do in this space where STIs, where clearly the change in HIV trajectory has had a huge effect on STIs, at least in men who have sex with men, and maybe the larger population?
Yeah.
So you talk and we'll listen.
So to strengthen the STI prevention for people with HIV?
Writ large, not just the people with HIV. Everybody's in two flavors now. They're HIV infected or uninfected, but it's status neutral. So everybody's getting something, and the behavioral activities are mostly in making sure they get their something. If they're HIV infected, it's keeping people on the continuum. If they're HIV negative, it's getting them on PrEP and keeping them on PrEP. This biological solution. Right. But the STD problem is not attended to. And the way we're starting to think about attending to it is to give people another PrEP drug, i.e. doxycycline for syphilis. But it just
Right.
seems not rational to me. So that's why I want you to
Right.
make it
Yeah,
rational.
so the, so when you look at this, when you think about it, right, you can't say that the growing STI problem is a result of PrEP because it predates PrEP. But you can tag it, you can tag it to, I mean, it's been occurring for some time, but I do think that the, you know, sort of the, you know, what Keys was saying, the sort of HIV complacency and I think is playing a pretty significant role. And I think that the problem that we behavioral people often face is that when we start talking behavioral interventions, everyone hears us say condoms. And condoms are you know, are nobody's favorite tool. So I think that what people miss is the breadth of the behavioral intervention. That includes things like partner selection, personal network analysis, communication skills training, empowerment, health services skills training. There's a broad array of behaviors and behavioral outcomes. It's not just all about condoms. And so I think, you know, if you think that STIs are stigmatized, we could talk about condoms, right? So condoms are pretty stigmatized. I do think that is sort of the broader problem with behavioral intervention scale up, is a fairly narrow view of it that kind of tunes people out right away. So I think that we can return to behavioral interventions now in an effort to reduce STIs and sort of rethink them and how they can reach the populations that need to be reached. And how can populations be motivated to engage in behavior change the way that gay men had been motivated to engage in behavior change by HIV. The seriousness of STIs, you know, STIs are often you know, the punchline in a joke. And so if people take STIs seriously, and if we can get, you know, communities more sensitized to the, you know, to the, you know, the problems that STIs cause, the infertility problems, the significant health consequences of untreated rectal gonorrhea, and any STI. I think that's got to be part of, I think, the mobilization to scale, to try to rescale up behavioral interventions.
Last 4 questions. Let's try to be pithy. Patty.
So just one is a comment. For women, I think also stigma is that if they're pregnant, that they're also blamed for the possibility that they're going to give the child something. So I just wanted to get that on the radar because we didn't talk too much about stigma in women, and it's a big problem. So, you know, I've been in this field long enough to know that the pendulum swings back and forth. And now we're in a really biomedical phase, and rightly so, because there's some really efficacious interventions. But how can we get it so that we're not always like knee-jerking back and forth, you know? So we didn't have much with medicine, so then we were doing behavioral. So, and you kind of alluded to it, but I don't know if you could speak a little more, like how can we be sensitive to all the whole full array of interventions we have?
Well, I mean, biomedical advances give behavioral interventions room to be delivered. I mean, like with PrEP being an example of that, with PrEP's kind of quarterly follow-ups for, you know, for kidney and bone density, or kidney and for kidney functioning tests, et cetera. I mean, those give providers an opportunity to have behavioral interventions. They introduce as a regular point of contact where patients can receive behavioral interventions. And there's some good examples of very brief sexual health interventions that are located in places like Callan Lord Community Health Clinic in New York, where peer outreach workers are on site at the clinic at all times and available to speak with people who are either interested in PrEP or once they're on PrEP who are interested in having in receiving some of these brief behavioral interventions that Seth reviewed. Yeah, so I see biomedical advances as an opportunity for behavioral interventions.
I tend to think of it as a false dichotomy, actually. So, you know, that behavioral interventions don't involve biomedical interventions, and biomedical interventions without a behavioral intervention can succeed. I mean, just look at the HPV vaccine, right? So it certainly had a very slow start because well, you know, as we heard, didn't engage. I mean, anti-vaxxers may be an important group of players to bring to the stakeholders table, you know. And so I think that it is a false dichotomy to think that, you know, that PrEP as a pill will prevent HIV infections without behavioral interventions to increase interest and uptake and you know, and sustained use, adherence and sustained use. So, you know, behavioral interventions depend on biomedical interventions for their impact. And biomedical interventions depend on behavioral interventions for their use.
Jeff?
So this is interesting, and Seth, you said something about condoms that goes to partly to my question. I've been sitting here feeling, I don't know if the right term is that there's this generation gap, or like some of the discussion feels like from another era. But I feel like this conversation is divorced from what I hear from any group of young gay men. You know, and I think it's real. We think with U equals U, with PrEP, we're worried. But sometimes people say, like, these guys don't care about STIs. I don't think that that's the case. I think they make decisions about what they value, and they'll say, yeah, I can deal with it. And so it's great to hear you say that it's not just about condoms, but I was wondering, do we have evidence of effectiveness of these interventions that aren't really about condom use? And I'm just wondering, like, in today's world, like, I think if you said you want people to use condoms all the time, you want to reduce partners, I think a lot of people are like, that's not what I want for my life. So are there behavioral interventions that say, you know what? We want you to make smart decisions about your health, and if you're going to go out and you're going to hook up with a lot of people, I still want you screened, I want you to be treated. If you have symptoms, come in. Do those interventions exist? Yeah, and do we know if they work, or are all our so-called effective interventions, are they really about just pushing condoms?
So what was the final question?
Do we have evidence of effective interventions that work that aren't just based on pushing condom use? Like there's a broader vision of sexual health that we might get behind, but do we know if these things make a difference?
Yeah, and the answer is yes. It was maybe a poorly constructed slide. Maybe that slide should have had more thought put into it, into the behavioral targets and the behavioral interventions, right? So it depends on what your target is. And so if you think about actually reducing STI without increasing condom use, I think what you'd be looking at are network interventions that get people in to get tested and treated. I really tried to constrain my talk, maybe mistakenly, to U.S. stuff. I didn't want to talk about anything internationally. And I ended up not talking about any of my own work because I haven't done an STI intervention in the United States in quite some time. But we just finished one in South Africa. And we had a partner notification intervention that actually demonstrated pretty good effects in getting people to self-notify their partners. So I think communication skills training in an STI context for partner notification and name revealing to DIS, I think that that there are skills training interventions for DIS about eliciting names and communicating with particularly stigmatized populations. I think that those are all viable options. I don't want to dismiss condoms, and I'm not. And condoms play a critical role, and they're a centerpiece of the interventions that I've done. But I do think that it is a problem in having a conversation about behavioral interventions, that it is the default that everybody turns to.
I was just curious on like what you think are the primary drivers of the increase in STI incidents that we've seen in the last few years. Like what are the primary drivers of the increase in STI incidents that we've seen in the last few years, in your view? Why have STIs gone up?
So, all right. I'm on the stigma panel, and so I'm going to go ahead and try to demonstrate how one might destigmatize a stigmatized condition. One of my hearing aid batteries died in the middle of this, hard of hearing, which is very stigmatized. Could you ask your question again? Yeah, I don't think your mic was on. If it was, could you,
Okay.
I couldn't hear your question.
In your view, why has STI incidence gone up in recent years?
Yeah. Oh, yeah. When I looked at the graphs today, I had a bunch of slides for the front end on the epidemiology of STIs, and I said they're going to already seen 1 million of those. And I know that there's concern in a lot of specific places, like San Francisco, places really scaling up PrEP. And so, I think that there are multiple drivers of STIs, but I have to say, when you look at the epidemiology over the years of the HIV epidemic, the better we were doing at suppressing behaviors that are associated with HIV transmission, the better we were doing with STIs. And for the past decade, we haven't been doing as good a job in suppressing the behaviors associated with HIV transmission, and STIs are scaling up. And as we scale up PrEP, I think we can just expect that to change. PrEP for HIV is a whole different conversation. And I think mistakes that are being made right now about how PrEP is being marketed and who's doing the marketing of PrEP. And I don't think that's unrelated to the problem we're going to see with growing STI.
Get quick. John, I appreciated your last slide about the social context and how that can modify the efficacy of a behavioral intervention. And so my question is, have there been efforts to intervene on the contextual factors that might shape the efficacy of a behavioral intervention? So I'm thinking some of the examples you all gave necessitate access to health care. So presumably you'd have to intervene first on health insurance, access to health care, to make sure that people can, benefit from that. Similarly, some of the web-based interventions, you'd have to kind of make sure that people have access to the internet before they can kind of take advantage of that. So are there kind of efforts in the context of behavioral interventions to addressing contextual barriers to those interventions to make sure that they're distributed in a way that's equitable?
Yeah. Okay. So I think there's like a lot of answers to that question. Maybe none of them great, but I think there are like a lot of answers to that question. So when interventions are delivered, they're delivered usually through some local service provider, often community-based organizations when they're funded, when the funding is there for them to do them, and of course local health departments. And I think that some places I think have done a better job at having a plan and sort of a strategic plan for laying the groundwork for multi-levels of behavioral interventions. So you're talking about a very broad-based sort of a level that would include things like social marketing and engaging stakeholders, and interventions like the opinion leader interventions that people have developed and tested that have been not just done with gay men in bars, but also with women in housing developments, and interventions that have worked with housing development councils, health councils, and women's organizations and Planned Parenthood clinics. I think that there's these different avenues that can create an environment that'll increase the efficacy of behavioral interventions on the ground. Those exist, but they rarely, in my view, they've been rarely coordinated because of the way that funding happens. Right, so there's an RFA from the state health department, request for proposals from health departments and community-based organizations to deliver this kind of an intervention. And then in 5 years, there's a different kind of an intervention, and it really is counter to a coordinated effort, right? And so I think that I think a more strategic and coordinated effort has been well articulated, like in the National Strategic Plan. We've had, and like the Syphilis Elimination Plan. You ought to read, it's kind of amazing, right? I just looked at it for this meeting, right? It's really amazing. It's this coordinate. So the CDC, I think, often has these they can articulate this coordinated plan, but their funding structures seem unchangeable to execute such a plan.
So I'm going to say a quick response to this, and then if you have more to say, you can let us know offline, but we're way over time. So from Dr. Salgankov, Alina Salgankov, she said, we discussed some of the gender-based differences in stigma. I'd like to know more about the state of knowledge of research on gender differences and behavioral interventions. Do we know what they are, and is there a need for more research in this area? So this is gender-specific.
Yeah, for me? Well, okay, so I would say yes, we know what they are, and yes, we need more research in this area. And so there have only, my thing, when I think about the evidence-based behavioral interventions for HIV prevention, it's a really interesting question, because aside from STD clinic interventions, I'm not so sure that I can think of interventions that have included both men and women. So in STD clinic-delivered interventions, we can look at the outcomes for men and women together. Otherwise, it's interventions that have been delivered to women in women's health settings and in community-based organizations that serve women, and the same for men and men who have sex with men. Although interestingly enough, for heterosexual men, it's only in STD clinics. And so so the answer is in one service delivery sector, in the STD clinic sector, I think we do know a lot about behavioral interventions for men and women. I think that we know that in STD clinics for men, behavioral interventions are pretty good at increasing condom use, and they're pretty good at increasing communication skills and condom discussions, and ultimately condom use with women. I think that we've also seen good partner selection strategies in men and women in those interventions. And so, yeah, I think for some interventions delivered in one place, we know a bit about the gender differences, but otherwise we don't. I can only think of one or two interventions that have ever done like a group intervention with men and women in the groups together. And there isn't any good reason why you really couldn't do that. And the studies that did do that, I think, found interesting results and an interesting dynamic that may have facilitated behavior change. It's hard to role play, for example, sexual risk reduction strategies for heterosexual people to do that with same-sex people in the group. So there have been innovative ideas around that, but I do think that there is a lack of a body of work. If you said, so what could you really speak to the differential effects of behavioral interventions for HIV, STD prevention with men and women from the same interventions, and I don't think I could say that there are.
All right, we could talk all day about this very important and immense topic, and Kay's has a question for you offline, but we have to stop there. Thank you very much.
Thank you.